Good morning, everyone. Give a few moments for people to join us here today. Good morning over here on Facebook Live. Those of you that are members or have my Zoom link are welcome to come over onto Zoom and join us here. And we can take part in question answer kind of stuff there. It's a little bit unwieldy to do it over here. Let's see, to start with a little bit of commerce. This is a regular meeting for members of the NeuroCentric Approach Online Academy. Those are the folks that have opted in to take advantage of the NeuroCentric Approach online courses that are available. You can go to learn more about that at neurocentricapproach.com. We've got both monthly and annual memberships available there. You get 35 hours of continuing education online. And you also, with the membership, get a discount on the in-person courses that I teach in this material. Those in-person courses are weekend courses that are 12 hours in length, currently an upper quarter and a lower quarter course. Our next scheduled course is in July in St. Louis. And you can find that there over here on Facebook. There should be a link there for the events page. But if you don't see that, just go to NeuroCentric Approach and look for the tab for events. And you can find the event schedule there. We also just penciled in a date in mid-December. Mark, you might be interested in this. Mid-December in Phoenix. The 14th and 15th is a penciled in right now. So yeah, we want to try to, those of us in the Pacific Northwest, certainly so today, like to try to lean on our friends in the southerly sunny climes in the wintertime to give us a continuing education opportunity down there so we can go dry out for at least a weekend. Let's see, what else we got? In my personal life, some changes in my practice locations and such. Some of you have come and done coursework with me and know that I'm affiliated with the athletes at Kabuki Strength Lab, a powerlifting facility here in Portland that I think probably has more world record holders per square foot than any other gym in the world. Kabuki's doing some restructuring. Technically, the way that things were organized at Kabuki, my office in the clinical aspect represented there within the Kabuki framework. My office fell under the heading of coaching and the gym, and Kabuki's going to double down for a while on their equipment manufacturing and fulfillment. So those of us that are involved in coaching, clinical, and gym are peeling out of formation, and we're opening up a spot in Lentz, the Lentz neighborhood in Portland, for those of you that are familiar with that. And that'll open up in, if all goes well, in June. I'll start seeing patients there in July when I get back from my vacation walk in Italy and a little jaunt across the water to Morocco for the month of June. And during that month in June, I won't be here playing with you guys. I ask that you take care of yourselves for a month so that I can go spend some good quality time with my son and my wife. Yeah, that's what I got. What are we going to talk about today? Um, I am open to suggestions from the group here. I had some interesting cases this past weekend. And I've been continuing the exploration of this intersection between the aging literature and the pain literature, more specifically to how certain changes in aging um, and or the accelerated aging associated with increased oxidative stress might factor into the observed failed healing response that we see in the pathogenesis of tendinopathy. And I'll share a paper with you guys that I found very interesting this week um, that was recently released in the journal Nature, very reputable journal. And we can talk about that if anyone is interested. Patient cases this week. One of our athletes at Kabuki, master's level female power lifter, presented with right lateral elbow pain of 1 week, no, 2 weeks duration, which occurred after the last meet that she took part in. She set world records in every event that she was in. So all 3 lifts, cumulative total, and once again got best lifter at the meet for the female category. You know, that is an amazing accomplishment, but it's the kind of stuff that at Kabuki we've gotten quite used to. We are disappointed when our athletes go to a meet and don't sweep every single one of the medals in their events. But she complained of this after her third and last pull, her deadlift. And she set a record on it, but she had persistent right lateral elbow pain since then. It's a little bit different. Her pull strategy is conventional with a mixed grip. In that particular hand is the overhand grip. Evaluation in the clinic, looking upstream. At best, I saw minimal, read less than 30% change in her pain with her index movement when I explored interventions to create some opening around a putative irritable nerve root in the cervical spine. And those changes, I then worked downstream, did not find much palpatory tenderness along the peripheral neurology affecting that area, which you guys know to be primarily the radial nerve. She didn't have any sensory changes downstream from that point to suggest the sensory component of that nerve was affected. And when I got around the elbow and palpated along the course of the radial nerve at the extensor carpi radialis longus above the elbow, not a whole lot of tenderness. She's complaining of anything that looks like a bench press now is her index. And her goal, she wants to get over 300 pounds on bench. She's been chasing that rabbit for several years, steadily progressing up, and we've got 4 pounds to gain. We need 4 pounds to get an all-time world record, and I think she may be the first woman to bench over 300. I'm not sure about that, though. So when I went in around the elbow, along the expected track of the um, radial nerve and palpated, especially taking particular interest in the course of the radial nerve as it enters and exits the radial tunnel around the supinator, and testing with supinator resisted and passive stretching of the supinator itself. I really wasn't able to reproduce the symptoms there. And that kind of surprised me. As you guys know my bias on this nerve thing. So I continued my palpation over the other elements of the elbow, um, in the posterior aspect of the elbow at the olecranon, no tenderness. Uh, when I went to the lateral epicondyle of the humerus, there's a jump sign there. I'm like, oh boy, jump sign. Wow, we had anything that looks like a fracture. I asked her, if she'd taken any falls to an outstretched arm. I know that she had recently taken up shooting, and had been, absorbing some recoil into that right shoulder and elbow, perhaps, but nothing that seemed to either aggravate her elbow with her shooting practice. This would be rifle, by the way. Um, and nothing to suggest that there was any kind of possible radial head pathology associated with impact. But when I palpated directly over the radiocapitellar joint, marked reproduction of pain. That was like, man, yow, that's it kind of thing. And as I stayed on that, my thumb, and rotated her wrist back and forth, to my hands, felt like there might be a bit of a malposition in that particular joint. This particular patient uh, is aversive to manipulation. Um, she's been stung by some chiros in the past, and it set her back. So we use it sparingly. In this particular case, I tried mobilizations, thinking about the possibility with the mechanism of injury of a traction injury that resembles what we learn in school for board exams as a nursemaid's elbow, where, where a kid goes limp crossing a street with a care provider holding onto their hand, and a traction injury there injures the either the anterior ligament or the radial ligament there, and from what we think might be occurring there, sometimes cause a bit of an entrapment issue right there, or a malposition of that radiocapitellar joint. And I did some traction. We got some improvements, sort of the Mills traction kind of thing that you guys have seen. Warren Hammer talks about it in his book, where you put the patient in a position like with a post or a solid object here at the elbow, and then you take like a towel and wrap around the wrist for comfort, and then you get a good tight grip on the wrist, and you provide a distraction on the wrist while you supinate and pronate. And I did that, and it seemed to be a little bit better, and yet it was still really, really tender right there over the joint. So I had a little discussion with her, apart, if you will, about manipulation of that radiocapitellar joint. Shared with her that I've seen it be remarkably helpful in what I thought was going on there with that potential malposition. Listen to me talking like a proper chiropractor here, guys. And she gave me a thumbs up with a lot of consternation, and I set her up in a posterior radial head manipulation and leaned into it, gave it a good solid thwack, and we got a booming cavitation. And she gave me that wide-eyed look and that scary thing in those places that we all go to in practice when you know that a patient is afraid and that they have verbally and at a gut level given you their trust, and you don't want to violate that. Especially when I've got a world record holder that is in training process and nationals are 8 weeks out. I don't want to screw something up there. So palpatory tenderness over the radial head was probably 50% less directly after that. She explored the bench type of movement. That was probably 50% improved. 2 days later, she texted me to say that her symptoms were 75 to 80% improved. Yesterday, she texted to say that she was 95% improved. Cool. So I don't know. Maybe we keep manipulation as a potential strategy for addressing meat-based tissues. Yeah, I think so. I'm not averse to manipulating a joint, guys. So hope you aren't either, in the right circumstances. Mark, you dropped something into the chat regarding elbows. What do you say? I have a short medial elbow case I'd like to share. Turned out to be cervical spine related. All right, Mike's yours, my friend. Take it.
So I had a kid. He's a carpenter. He's in his early 50s. He's robust, and he came in with medial elbow pain. And what I first did was trigger point work on the medial, just distal to the medial epicondyle, and gave him strengthening exercises, curls and what would you call that? An ulnar deviation type of curl.
Yeah,
and he came back a week later. It was no better, and so I said, well, this is not the whole story, and we did various. This is all by memory, and it's if you hadn't had an elbow case going, I probably wouldn't have done this because it's off the top of my head. But he said some obvious problems at C5-6, and what I tend to do for that area is I call it an anterior cervical subluxation, if you don't mind the term, meaning there's a lack of flexion and lateral bending of that segment. So we did our, and I don't like high velocity manipulation of the front of the neck, but I did a muscle energy type thing for that area and released it and showed him what I call chin to collarbone, which is an exercise that attempts to release the scalenes by strengthening the deep neck flexors unilaterally. I sent you the blurb on that one a couple of weeks ago, Philip. And anyway, and he came back the next week and said, "Oh, I'm much, much, much better." So it wasn't primarily the elbow. The elbows where the symptoms were, and the neck was where it was apparently seemed to be where it all was coming from. So, and I'm not as sophisticated as you, Philip, especially off the top of my head with this area. But it's like I'm good at what I do, and I did it, and it helped him. So I'm a happy camper. He's a happy camper.
There you go. There you go. And that again, I think we all have to be intellectually honest here that there's a lot that both I and you and the rest of us that are listening here, we work a model that has a narrative that seems to make sense, but we're still on the edge of some of that research. It's nice for us to have a good story to help explain why we're doing what we're doing. And it's also nice to be able to change that story as the evidence changes and matures. And I'm willing to do that and try to do that with this particular model, the neurocentric approach thing that we are playing with here. Alex, you're on here today. Do you have any comments or anything to share about that? Or shall I just go right on to talking about bacterial flagella?
Oh my goodness, how fun that sounds. I do actually have an interesting case that happened this week, and I'm kind of debating back and forth on this one. This was a patient that had completed our 6-week impact program probably around Thanksgiving last year. And so once they're discharged, they typically don't come back. But she'd had a follow-up with the doc that got her into the program, and decided to stop by the front desk, and they were feeling kindly towards her because she was one of our favorites. She'd done really well. But she's a high anxiety patient. She's probably mid-30s. She is approaching retirement age, but she is in a job where they won't let her go because they don't have enough people in her line of duty in order to allow her to retire.
And remind folks that are listening here, Alex, of where you are and what you do and where you work.
Oh, yeah, I'm the chiropractor at Madigan, which is at Fort Lewis up here in Washington, serving Army, Air Force, some Navy, and some Marine Corps. This happens to be an Army reservist, and she's an activated reservist. And because she's needed in her MOS, they have her in active duty status. So she suffered some.
Alex,
yeah,
the average bear doesn't get to retire in their 40s. These are people who put in 20 years in the military. And
exactly. And that's something to consider. Right. Once you've done 20 years in the military, it's basically your half-life. You change into another career and can sometimes work for the military in a civilian status or work for some government contractor and still get a pretty decent salary and as well as your retirement, which is well deserved because of some of the things that they do in the military. It's pretty rough on them. Anyway, she came in and she has this new rash, body plaquing rash, just about everywhere. Kind of looks like ringworm, but different. Sparing her face, but it is on pretty much everywhere else. Her hands, her arm, and back, pretty much anywhere. And at the same time, though, her main complaint was neck pain. And we'd helped her with her neck pain before, so I was taking a look at it. She has a 2 centimeter lymph node in the left supraclavicular fossa in the anterior cervical chain, with 2 that are smaller adjacent to it. It's been examined on CT. They're beginning to work it up, but she's coming to me with neck pain. And her body's probably doing something to try and shut down that lymph drainage process for whatever reason, for whatever's going on. And the debate that goes in my mind, are we benefiting by helping them move better? Or do we want to help the body reinforce the non-movement pattern? Because obviously her lymph nodes don't want to drain whatever's going on. And they're working really hard locally. What are you guys' feeling on that?
The first thing that comes to mind, and was this a recent case, Alex? You said this
Yeah, this
past
was last week. She came into the
Okay.
clinic, and it's still being worked up. She goes in for her biopsy next week.
And the lymph nodes in the past, with any of your work with her on the neck, did you note any lymphadenopathy?
Never. This is a big, fast spring up.
So I will say that just in the last 2 weeks, I've seen two different patients with neck pain that had anterior cervical chain lymphadenopathy. And the working theory that we've got on that with this new lymphadenopathy that's non-painful, they were both being quite affected by the very high pollen titers that we've been having
Oh, yeah.
recently.
Yeah.
And certainly with the blessings of this kind of weather that we're having here in Portland today, with it just pissing rain all day long,
Yeah.
is that the air is clear. But yeah, poplar, alder, birch
Yeah, it's
are
all really high. And that could help
okay.
explain her plaquing rash too, if she's just having a systemic response.
Yeah. And
Yeah.
so, usually what we'll see there is that if they're not, that issue is up in my grill a little bit more as a man of a certain age,
Sure.
having some BPH, the availability of antihistamines to me is long gone now. The amount of discomfort from urinary retention associated with taking an antihistamine makes that very
Oh, wow. Yeah.
consider. So the places that I've leaned into with that have been turmeric. I've tripled and even quadrupled my stack of turmeric and a now product that combines quercetin and bromelain.
Yeah.
And I've been able to get through. It very clearly improves my symptoms, and I've had these patients with this kind of stuff to improve a bit as well. Because if that mucosal, biggering in the sinuses occurs to the point that we get a sequestration in the sinus, then at very least you're going to develop some serous buildup and pressure and tension there, but the possibility of secondary infection then goes way up, and
Sure.
that could be kicking the lymph nodes into high gear there as well.
Yeah.
So that's the first thing that comes to mind.
Okay. I guess my main question was, you have a patient with suspicion and possibility. She has burn pit exposure and all this other stuff. So I'm thinking there's a possibility of lymphoma. And with that as a
Absolutely.
possibility,
Get a
how do
whole
you feel about
patient.
manipulation and massage, etc.?
I would be careful of it. Like
Mhm.
Mark, I'm judicious about my cervical manipulation. And given the evidence that suggests that we can get damn near the same improvement by doing lower force manipulate or mobilization kind of techniques without the attendant same admittedly incredibly small risks associated with cervical manipulation.
Mhm.
My opinion here, I think, doesn't really matter. I think an exploration of the evidence on that would probably be worthwhile. I'm not conversant with that in this particular episode, but what I would suggest is that probably some of the things in terms of cervical lymphadenopathy that we've seen, that I can recall from papers past, are that centered around chiros touting the purported benefits of cervical manipulation for these kinds of cases probably have more to do with just moving lymph and helping to facilitate lymph drainage, and probably those could be just as easily attained or very least tested, and maybe variables controlled by doing very low impact lymphatic drainage type of massage through that area and see if they get better now.
Yeah, I think I lean more towards not encouraging the distribution of whatever's going on at this time, because the body's definitely trying to lock it up. We did work on her headache. So we took care of trigger points for the headache because the neck pain was referring upward. And then I did do a rib adjustment because her shoulder was pretty locked up with it. So we took care of that too. But I went very conservative with her until we get our results next week.
Yeah.
Yeah. I'll keep you
about
guys
that?
posted on what happens. She is going to come back. I'm having her come back to see me next week after her. She's going to need the emotional support if nothing else. So
Yeah.
I want to be
Yeah,
there
good
for her.
call. Well, imagine
Yeah.
all that, that's straight up doctoring right there.
Yeah. Yeah, we got
Not
to take
just
care of
not
them.
just very quickly throwing a hammer at the nail, right?
Right. Exactly. Yeah.
Good on you.
Yeah, her the doc that had referred her back to me wasn't even aware that she was being worked up for this, because when he saw her was probably about 3 weeks ago. So we were just in her forefront of her mind. So she came back to us for the chiropractic care.
Copy that.
Yeah.
All right. Let's see. James Gordon, welcome in. You're welcome to chime in if you have anything to contribute or want to say hey. If not, I am going to take off on a little bit of a tangent. Some of you know that I've been talking for some time about that I've got this NeuroCentric approach tendinopathy course on my desktop that has literally been in process for 6 months now. As I continue to explore the pros and cons, merits and demerits of the idea of NeuroCentric approach, bringing something to the table in regards to the pathogenesis of tendinopathy. And my working theory is that the failed healing response that's observed in the pathogenesis of tendinopathy, that the neural ingrowth we know is important, very similar to the neural ingrowth that we see after acute injury in a disc. That the neural ingrowth is a typically self-regulated, limited process that occurs over a period of weeks, wherein we have neurovascular ingrowth into the portions of the deep tendon that are typically avascular and aneural that have sustained a mechanical overload. And then you have an ingrowth of the neurovascular elements from the tenosynovial sheath. And that in the acute phase, we would refer to as tenosynovitis most correctly. And we would treat that differently than a tendinopathy, right? That would be a, let's peel back your activity and your loading strategies on the tendon and let nature take its course, and try to support that with other things like, gentle movements, appropriate loading, hot, cold contrast, topicals, things of that sort. But for reasons that we've been dancing around discovery of for the better part of 20 years now, the pathogenesis in some people of tendinopathy occurs after that acute healing response. That acute healing response typically is limited to somewhere between 2 and 4 weeks, maybe. And then there's a cell signaling process that is expected, wherein the nerves and blood vessels are, you might say, given the signal to retract and outgrow from the deep tendon. And those are your tendon injuries that heal, and after a period of time, the patient's fine and they get up and get back to life. In those cases that it doesn't happen that way, we have an increase of granulation tissue. Sometimes that increase in granulation tissue, the changes of the morphology of the tendon can actually be painless over time. But but it does statistically increase the risk of outright tendon pain in that tendon and mechanical failure of that tendon to some degree down the road. So finding those morphological changes is, even if they're painless, is a worthwhile thing for us to do, and then start a loading strategy on that tendon with heavy, slow load to try to reduce the injury likelihood going forward. The place that my recent interest in this was tickled once again was a paper that came out. I'll share screen here. Paper that came out last week from a bunch of researchers, I believe in South Korea. And here is the paper from Nature Communications. The mucosal TLR5 activation controls health span and longevity. So you guys know that I am in that odd spectrum of people out there that are receiving some justifiable humorous nudges and effacement by known as biohackers. So I feel like I got a lot of stuff I want to do before I check out of this plane, and I feel like I got started kind of late since I'm mostly retired in my 20s. So I am doing what I can to try to live a longer and healthier life. Part of that's motivated by some desires to avoid cognitive problems that I am genetically predisposed to. And among the things that I am doing, I've been on a ketogenic diet to help with those systemic neural challenges for 6 years. I also am taking rapamycin, 6 milligrams weekly. Started relatively recently again, because mainly it's been hard to get a source that's not god-awful expensive. And what I found, for those of you that are interested there, is Cost Plus Drugs, Mark Cuban's Cost Plus Drugs. All the drugs on there in their dispensary are 13% over cost. So everything is fair, transparent, and they put sirolimus, aka rapamycin, on their formulary not too long ago. And I managed here in Oregon to get a prescription for that from my naturopath. So I'm on the rapamycin. I'm also on acarbose, which is an old school diabetes drug that doesn't even affect liver. It just takes, its effects are entirely in the small intestine, where it interferes with the digestion of polysaccharides and results in a improvement in the profile of short-chain fatty acids that are known to have health-promoting effects further down in the bowel. And the polysaccharides deeper down or further down in the intestinal tract then cause gas early on, flatulence, which is the big thing that most people see as a side effect and they stop taking it because of. But if you stick with it for a bit, you start to grow the critters in your gut that metabolize those polysaccharides, and that gives you the observed short chain fatty acid profile improvement in the gut. That short chain fatty acid profile change improves gut integrity, and that can help with leaky gut and food sensitivity and food allergies, and that can change the microbiota over towards something that resembles what we observe when a patient has a very high fiber diet. The ITP protocols or ITP studies that some of you may have seen the podcasts with Rich Hall and Peter Attia. There's been a couple of those that I'm aware of. And these are studies where the 3 different research facilities using a non-cloned mouse model. These facilities are funded by the National Institute of Aging. Those facilities will receive recommendations from a variety of different researchers to explore their intervention of choice. Intervention here being drug or nutraceutical, something the mouse can be given. And the combination of rapamycin plus a carbose in that mouse model has now shown in 3 different research centers around the country to confer a 30 to 34% improvement in lifespan and health span. So that's pretty compelling. It's also in a mouse, so we don't know how it trends over to humans, but the cool part about those 2 drugs, acarbose and in this case sirolimus, both of those have been used in humans for a long period of time, and they are known to be safe to humans. So consider it an off-label use for both of those for the potential benefits of improving health span and longevity. And I'm willing to pay the price for those to try to get that. And that leads us to this particular paper that I've got on the desktop. In this particular paper, and this I think some of you will find interesting, since all of us became, at least temporarily early on in the pandemic, armchair immunologists as we struggled to learn and relearn the things that we once upon a time were exposed to in our pathology and cell biology classes regarding the innate and acquired immune systems. But many of you, either directly as we age or in working with your aged patients and around the pandemic, know that as we age, our immune system changes in its ability to be able to manage various exposures to things. And that innate immune system is that first arm of the immune system. Hats off to my cell bio. Actually, I believe at this point in time, he was teaching physiology teacher at Western States, Mark Kamensky. And I remember his, to this day, 21 years, actually would have been 25 years later, his explanation to explain the handshake between the innate and acquired immune system, wherein the T cells and the neutrophils and the macrophages and the innate immunity first exposed to some sort of pathogenic challenge He likened it to a battlefield where these particular knights, if you will, rushed in and they fought bravely against the invaders. And when they would slay the invader, they would literally rip its head off and stick it on a pike and parade it around the battlefield so that the acquired immune system, your B cells, could see elements of the invader and remember the elements of the invaders, of those invaders, so they could remember that face, so that if they see that critter out there on the battlefield, then those B cells would know that they were not friendly and they're the ones that need to be attacked. I always love that. Thank you, Mark Kaminsky. He was the first person that told us about Google. How about that? So, this particular aspect of the handshake between acquired or innate and acquired immunity is something that we all learned a bit about in COVID, because a lot of those RNA vaccines were about ripping the head off, if you will, of the COVID critter. And the particular aspect that was being utilized were the spike proteins that critter uses to assault various cells in the human body. And that's kind of where we lean into this particular paper. Here they used an interesting compound that was a fusion protein that contained flagellae from particular strains of bacteria. Now, these flagellae are non-pathogenic in and of themselves, but they belong to particularly pathogenic critters like Vibrio and such. And they are able to isolate that and then pair it with a pneumococcal virus, proteins from a pneumococcal virus, and made it into a nasal delivery and gave it to a bunch of mice. And when they had noticed previously, when they were using that for other reasons in the mice, they noticed that one of the things that occurred with the mice is they tended to live longer, and they tended to demonstrate a bit more sociability. They exercise more, they move more, et cetera, et cetera. So that's what caused them to lean in on this study and explore it from the aging perspective. And fascinating thing is they gave this stuff to these mice every 2 weeks, starting at 600 days of age. Now, in a mouse, that correlates to around about a 60-year-old human. And they gave that to those mice in the treatment group. They also did a control. They did that in that treatment group until the mice expired of a natural death. And then they examined a variety of different aspects associated with lifespan and health span in those particular mice. And those things included stuff like bone mineral density, the activity that the mice demonstrated in their enclosures and such. And lo and behold, they got an improvement in lifespan and health span. That's important because no one wants to live a long life if you are in really poor health. So the health span is probably more important. We'd all like to live a healthy life and then croak on a, while we're doing something fun. but they noted an improvement in lifespan and health span that rivals that of rapamycin, around about 30%. That's pretty cool. So the thing that they were manipulating here is one of these things called toll-like receptors, TLR, and this particular one is toll-like receptor 5. And now these receptors live on various cell strata in the body. Some of those are immune cells like macrophages. And we express some of these toll-like receptors upregulate immune response in certain areas due to exposure to certain pathogens. And the TLRs are kind of specific to certain pathogens as well. So groups of pathogens, and maybe even groups of portions of pathogens, in this case, the flagellae of a variety of different bacteria that humans have been exposed to since we crawled out of the muck and mire, so to speak. But the TLR5 activation, they found to be the particular interesting one. And they found changes in the intestinal villi structures, an improvement of gut integrity in these animals that were receiving the nasal application of these compounds, which tickle, think vaccination almost, tickle the innate immune response. So that's fascinating stuff, a full body response to that kind of stuff. And as I started to explore this TLR5 trigger, lo and behold, what I found was that there's a body of research out there regarding that and tendinopathy. So the upstream things in the development of tendinopathy, pathogenesis of tendinopathy that have been noted, some of those upstream things, we see an association or an increased prevalence of tendinopathy in patients that have diabetes, hypercholesterolemia, obesity, and these items are things that cause increased oxidative stress on the organism. That oxidative stress can alter the TLR profile in an individual, reducing or changing their immune response to certain things. And that axis between immune response, mechanotransduction, and pain is a fascinating area that I am very, very, very interested in. And that's what I'm trying to see if we can lean into a bit with this sort of neurocentric approach model by looking at the systemic effects, as we talk about in the coursework, looking at the past health history, the family health history in that individual, to look for these issues that are associated with mechanical sensitization of peripheral neurology and how it might be associated and or related to these kinds of clinical phenomena. So that's what I got there today. That was my geeky stuff for the week. I'll stop sharing. Come over here. All right. Mark says that was a vivid image that that Mark Kaminsky gave us there. Yeah, it's stuff. It's always fun to have those memory cues that are delivered in such a way that we remember things like that for many, many years. Something to keep in mind when we provide explanations to patients there.
Hey, Philip, one question. The papers that you feature in these Saturday morning things, I don't always grab them because I may be walking or whatever. Is there a way to, for you to put something out on NeuroCentric where we could at least look at the abstracts of those papers?
Absolutely. I've done that as well, Mark. As a member, you should be I can check on the back end here. I'll do it later once I'm off here. But you should be also a member of the NeuroCentric Approach community. And that community on the site, the academy .neurocentricapproach.com, the NeuroCentric online community. I put a link to the recordings every week when we do these. And if I cite any papers and folks are interested in them, I'll pull the full citation and park the full citation right there as a PDF. So I'll put that on there later today or tomorrow when I am able to get to that. Cool.
Perfect. Thank you.
Cool. And that's one more benefit that those of you over there on Facebook could get if you were over here on Zoom, because you're a member at the NeuroCentric Approach Online Academy. So thank you for those of you over here on NeuroCentric Approach, over here on Facebook, and those of you over here on the Zoom call. You guys share the love, tell your friends and colleagues about what we're doing over here, and see what we can get in terms of growing the community over time to try to help improve patient outcomes and patient care. Worth noting, something on my radar as recently as yesterday, some possible locations for a NeuroCentric Approach clinic. Wouldn't that be cool? I wonder. Branding the NeuroCentric Approach name as a clinical model and developing that brand over time. That could be something that would be of interest to folks out there, but something has come onto my radar as one possibility there, to be able to walk into a scenario within a health club and move an existing clinic over to that NCA model. So more on that if it develops in the future. Okay, doke. Here we are. It's been an hour. You guys be well. Stay curious. Stay compassionate. Take what you've learned. Go help some people. I'll see y'all next week. Cheers.